So thanks very much, and thanks. I want to start off with the stuff we do agree on. So we agree that we need better prevention. This prevention is an unmitigated disaster in our area. We also agree that PrEP works, and it works much better than I would have anticipated if you swallow it. It also seems to work in the real world, in gay men and in discordant couples. It works in women. I think I hear this often. It doesn't work in women. It does. We've got evidence from Partners PrEP. It seems, I disagree with even with incomplete adherence, even if you don't take it every day, it seems to work pretty well. Only people who are worried about the resistance are the people doing the studies and people with deep investment in resistance studies. I personally don't think there's anything to indicate there's any public health worry about it. And we haven't seen any risk compensation like we haven't seen with any other bloody HIV prevention. So all of these things, I think, are, by the way, they're not reasons not to provide PrEP, but I think they're good reasons. And just to indicate conflict of interest, Gabby and I are involved in a large PrEP study in Johannesburg among sex workers that has just started to enroll. But let's be clear, we are going to go cap in hand in a very poor situation at the moment, asking for more money for another intervention in a long field of HIV prevention which hasn't worked in the past. So going forward, we're asking for something that's expensive. It's going to need us to get access to difficult groups. We're going to need lots of engagement with a very unfriendly healthcare system. We're going to need lots of it. We're going to at least need them to swallow some of those tablets. And finally, the side effects are an issue. Gabby's going to talk about the cost, but the cost is a major concern, mainly also because the chemicals which go into tenofovir, being told, are sort of, to get to the 2020 targets that WHO set, is going to be very, very onerous on the API manufacturers that make these chemicals, and now we're going to use it for PrEP as well. The prodrug tenofovir, TAF, the tenofovir something I can never say, is an option in the future, but it's probable that we're going to have to redo the studies using this drug in place of tenofovir. And finally, the cost of HIV testing is a major contributory factor to programs around PEP. You've heard about adherence being the Achilles heel. There are people we know will take it. If you don't take your tablets, it doesn't work. We know that from every aspect of medicine. All these studies seem to indicate that. But the problem with adherence is that we know that high-risk gay men and discordant couples who've internalized risk take their drugs. Everybody else seems to have a problem doing it. And simply saying we're going to make this better is not good enough. For an expensive intervention, we're going to need better proof. And in many of these studies, women didn't take any of the tablets. Some of the studies had to be shut down for futility. And if we can throw an expensive intervention to people who don't swallow their tablets, it's a waste of money. And there's no clear adherence measure like we have with ARVs, where we have a viral load. Then we have to go and find these groups. And sex work is illegal in every corner of Africa. MSM, we're doing everything in our power to chase them underground. And just look at that stat there, what the number of African countries it's illegal. In 4 countries it carries the death penalty. Why would they come out of the woodwork to actually volunteer themselves for these studies and for these interventions? And as for adolescent girls, they are an absolute disaster. You try and discuss parents and teachers trying to get sex education, let alone something that acknowledges that they're sexually active into the schools. And in the general population, discordant couple programs are notoriously hard to recruit for, so even making that available is difficult. People are very dismissive of safety, saying, all the studies show it's very safe. The studies do show it's safe, but you have to have a very low tolerance for safety signals when it comes to giving HIV-negative, completely healthy people a drug. We have limited safety data. Remember, HIV-negative safety data is not the same as HIV-positive safety data. We've seen that in several drugs. At the moment, we require kidney functioning testing. Are we going to be brave enough to dump that? What about hepatitis B? Are we just happy to dismiss the bone data? And what about the repeat HIV testing that needs to happen again and again and again? All of this to make this a safe intervention. And I don't agree with Linda Gale. I think that treatment's unbelievably effective. And in most of the programs where they show this loss to follow-up or this resistance, if you go and burrow down, patients fall off the program because they're not terribly friendly. This is the same program that's going to deliver PrEP. And what's interesting is the life expectancy in HIV-positive populations is now higher than in the general population. So the kind of, we must stop them getting HIV is maybe not such a compelling reason any longer. And maybe it's better to treat the relatively few people who get HIV with proper treatment that's safe than it is to spend huge resources on trying to keep them negative. And the treatment system is unfriendly, let's face it. I'm not going to, are you going to wander into the average clinic and discuss your sex life with people openly saying, I'm having high-risk sex, please hand over these drugs? I don't see that happening in South Africa at any time soon. I very much doubt in your clinics it's the same story. Are you going to put up with the queues, with the annoyance, everything else that goes on there? I find it difficult to believe. And at the same time, we're consuming what is an extremely precious human resource. People often say to me, what are the ethics? We must give more money to prevention. If you've got somebody with HIV, they have one chance, and it's antiretrovirals. If you have somebody who's HIV negative, they have a whole menu of safe sex options that they can do to remain negative. For me, ethically, there's nothing to debate here. It falls firmly on the side of treatment. So HSV2, let's be honest here, HSV2 is an annoying viral illness. That's all there is to it that might help propagate HIV. To put huge resources into this as a major reason to prevent it is, as was put forward earlier today, I think is nonsense. So in conclusion, I think we have an exciting but very complicated intervention. It's going to require a lot of resources, and we're going to have to be very, very careful how we plan around that. The cost has to be addressed. It's not just the cost of the drug, and Gabby's going to talk about that, but at the moment I am very worried that, particularly in the general population, that people think this is cost effective. There is the access system that we need to look at. We need to make access to it much more friendly. And as I said to you, I don't have confidence in at the moment that the average clinic is going to be able to roll this out. The safety considerations, I think, are being dismissed too quickly. I think that we need to think very, very hard about that. And finally, we need to very carefully think through before we start prioritizing this as an intervention. I think people are still looking for the magic bullets when it comes to HIV prevention. If anything's taught us in the last 30 years is that there are no magic bullets. This is a difficult thing that we need to think very carefully about before we just throw it out there. Thank you very much.